Kher and Vinayak, Dr. Agrawal.
Thank you, Pradeep, for that wonderful overview of this topic of PPI usage with chronic kidney disease. Before I open it for questions and answers and then discussion, let me go over some of the recent guidelines. And you talked about the mechanism of chronic kidney disease with ESRD, and you also emphasized that one mechanism could be because of the acute interstitial nephritis quickly developing into chronic kidney disease if we don't identify this, and that's an important issue. We find it very difficult to identify people who develop acute interstitial nephritis unless there is a very high index of suspicion. Otherwise, most of the time, any rise in the creatinines that you might see may be alluded to some other causes and may be alluded to the changes in the volume, or may be related to chronic kidney disease of other causes, and rather than incriminating the PPIs for this. So PPI as a cause of acute interstitial nephritis, you emphasize it strongly enough that is a real thing. It happens, is being documented by biopsies, and the higher incidence has been documented in almost all the databases that have been looked at. You also emphasize that chronic kidney disease can develop irrespective of this pathway. This pathway is not essential for development of chronic kidney disease, and this might happen. And what is the role of hypomagnesemia contributing to development of chronic kidney disease? That might also be a cause. Dr. Vinayak is sitting along with me, and it would be important to look at PPI and the heart. I'm sure that he will talk about it later, but there is a mechanism which has been postulated, and that is through the asymmetrical dimethyl arginine pathway, and that is leading to ADMA, increase in ADMA. PPIs suppress the hormone which metabolizes ADMA to DMA and citrulline, and that is being documented in this slide. This DDAH is suppressed, and with ADMA being elevated in this population, that suppresses the nitric oxide synthetase, and therefore there is decreased nitric oxide, and that leads to vascular homeostasis alterations and all that. So that's one of the mechanisms for increased cardiovascular or vascular toxicity related to PPIs, which may be also leading to higher. The association we will talk about during the discussion inside. There is some increased other associations which are occurred with gastric cancer and in patients with GERD, and also associated with proximal as well as distal cancer or unspecified cancers. Esophageal squamous cell carcinomas have been also specified. So there is some evidence to suggest that. I think PPIs, in my opinion, are probably an excellent drugs. They were designer drugs designed to treat acid peptic disease. The only problem with PPI usage has been the long-term uninterrupted use of these drugs beyond their indications. Normal indications for their use should be maybe about 12 weeks at the most, 8 weeks, 12 weeks, 16 weeks you can extend it, maybe in certain conditions like Barrett's ulcers or something like that, maybe for a longer period of time, 6 months or so. But continued usage beyond those indications, I think, is the problem, and I think hydrogen ion is essential for preserving the microbiome of the intestines, which is essential for even our own survival. The infections are controlled by these, and otherwise these patients will get higher rates of infection, and that has also been documented in patients who are on very long-term usage of PPIs continued for more than 3 years. They have documented that there is increased incidence of enteric infections in these patients. There are a lot of guidelines which have started coming now from various associations on de-prescribing PPI usage, and I think that's this one suggesting family practice. You can see that they suggest that there is an inappropriate PPI prescription both noted in the hospitalized patients all across the world, and therefore they have suggested that 68% of hospital inpatients did not have an inappropriate indication for PPI, and Dr. Arora also highlighted this in his talk, that one needs to probably de-prescribed. These are not harmless drugs. All drugs have to be considered to be potentially harmful, all drugs. And PPIs are no exception to this, and I feel that considering this, I think it's important that this association, even if the cause and effect may not have been proven by strict, rigorous scientific analysis, even the association of PPI across these databases, large number of patients in these databases going to more than 100,000 to a million kind of population, if you see this association, if there is no good indication for continued use of PPIs, I do not see why one should be continuing to use PPIs in this condition. So it has to be looked in that context. This slide was shown by Dr. Arora as well, that almost every patient in India, every person in India is using 5 to 7 tablets of PPI. And the reason why Dr. Vinayak Agrawal is here is basically that many patients, cardiac patients, are on antiplatelet agents, continuing probably for life. They are on anticoagulants also, which most likely have to continue for life. And because of the fear of bleeding, many of these patients are on PPIs by physicians because they feel that they may die because of the bleeding. And I think this fear, and if you looked at the indications in which the FDA had approved these drugs, prevention of GI bleed because of antiplatelet agent is not one of the indications for prolonged usage of these drugs. So I think this fear we will discuss again, and I think Dr. Vinayak will highlight some of these points as well. This is Drug Watch again suggesting that there are large number of legal suits which have been filed in US being a litigious country. So you can see that large number of 12,000 sort of cases have been filed against the adverse effects related to these drugs, and I'm sure this is going to get, this has happened in last few months, and that's basically because there are new guidelines now coming up, and that's where people are getting sort of things. This is tapered down PPIs from Washington State Healthcare Authority. Now try to discontinue PPIs after 4 weeks. This is what, and taper down PPI charts and look at the charts of the patients and try to see whether we need to continue it beyond 30 days or so. The question I think most important from these messages is basically that we should look at these prescriptions, try to see whether there is an indication. If there is an indication, continue to use it. But if there is no indication, just to continue these drugs, thinking that they are safe drugs, is not necessarily true. And I think as a physician, I would not give any drug if it is not indicated. And I think based on that concept, I don't see a reason why one should continue PPIs lifelong or for a long period of time. And these are all guidelines. You can see that NHS in UK again suggesting that avoid using PPIs for more than 8 weeks, review PPI treatment after course correct completion, step down to the lowest dose, use short term, consider discontinuation after certain period of time. And same again, safe usage from Wales Medicine Strategy Group, again from British Gastroenterology Medicine Management, again similar kind of that you should use the lowest dose for the shortest duration and consider either lowering or stopping completely. And I think that's what all these hospitals and various, so longer the exposure and higher the risk, you already, Dr. Pradeep Arora showed that, that you should not give it for a long period of time. And continued exposure, not only that this is incriminated in incident chronic kidney disease, but progression of chronic kidney disease also is increased with continued use of proton pump inhibitors. So I think there is definitely a reason to sort of reconsider the continued use of PPI in these patients. I think with this I will stop and I will open up for discussion. And before I take up the questions from the people, I think I would like to request Dr. Vinayak to tell me as to how important is acid inhibition in patients of cardiology, especially if they are on these antiplatelet agents and on anticoagulants?
So actually, I feel that this discussion is even more pertinent and important today because I am deeply, affected by the indiscriminate use of PPIs today. If you look at the 2010 AHA statement, consensus statement which came in, where there was a controversy about clopidogrel use with PPIs, especially esomeprazole and omeprazole. They had refuted that this interaction caused decreased efficacy of clopidogrel in patients who had stents. But then while they were analyzing the data, they realized that a lot of the patients who were receiving PPIs did not need to be given PPI even after a dual antiplatelet therapy. So the patient who were at low risk of bleed, GI bleed, or at lower overall risk of bleeding, there is no need to prescribe PPIs at all. It is probably reserved for people who have a documented history of ulcers, who have a higher GI bleeding risk, maybe elderly individuals, severe esophagitis. These are the patients where we would like to give PPIs. Again, the duration is not specified, but I would say that a lot of patients are kept on PPIs for years together without any solid data behind it. And I think that practice should be discouraged. As we are now, there more and more data is coming in which is showing the adverse cardiovascular effects of PPIs. It is not substantiated in randomized controlled trials yet, but there are large observational studies running into 1.5 lakh people being, in these observational studies, and they have shown that there is increased mortality, all-cause death, which should be investigated. So there is a red herring there. We should be very careful about an indiscriminate use. If you have a good reason to give PPIs, we should. Otherwise, there should be a judicious use of them.
Thank you, Dr. Vinayak. Pradeep, I think there are 2 or 3 questions which are related about AKIs, and let me put them together. That one is that how long it takes for the PPIs to cause AKI. You had talked about it in this, and also that are there any other metabolic alterations which occur with continued use of PPI in addition to, say, hypomagnesemia and hyponatremia you talked about? So that's, I think you can take them.
So
And
acute kidney injury yeah, go ahead.
Yeah, you can go ahead.
So acute interstitial nephritis, what classically we know is it happens antibiotic. You took it for a week, you develop acute some symptoms, peripheral symptoms. But with PPIs and many other drugs, these symptoms may be subtle and may not be there, especially fever, arthralgias, or rash, and it can happen after several months. So in fact, unless we do blood test, you will not be able to find out if patient had AKI, and that is the biggest Achilles heel in diagnosis of PPI associated AKIs. So that is why it is important to use PPI when it is needed. Regarding metabolic disturbance beside 2, as I said, hypomagnesemia, in that FDA, when they looked at the side effect of PPIs in 66,000 patients, 60% of patients who had hypomagnesemia had hypocalcemia. And some of the time, if you look at the causes of hypokalemia, severe hypomagnesemia is one of the causes of hypokalemia. So how does it work? If you remember Lasix, it blocks sodium potassium 2 chloride, but if you have serum magnesium level less than 1, it acts as a loop diuretic. I mean, that is what the mechanism is for hypokalemia in these patients. And I had seen this hypokalemia as well as hypocalcemia beside hypomagnesemia. In United States, they use it very indiscriminately, PPIs, especially everybody's doctor like us. In a sense, they develop anything, like Dr. Kher was saying, burning one time and they are on PPIs because it works. and this is available over the counter. So those are the metabolic.
Pradeep, there is also a request that Dr. Akash from Bandra wants to have your slides on hypomagnesemia, and I would suggest that, do you have any? No, I think Pawan will maybe send it to them if you have no objections. You have to first say that you
absolutely no problem.
Can your slides also be given whosoever wants it? As long as they, whenever they use these slides, I think they must acknowledge that this belongs to Dr. Pradeep Arora, and I would, that would be very, very important. And no, I consider it very important that whosoever slide it is being done with some effort. So I think it should be very important to acknowledge that this is a slide which was provided to you by this person, and it is with his permission that you are using this slide. So I think as long as they do that, I don't think you don't have any objection to.
No, I definitely don't. I actually give my slides when I give lecture to my fellows and resident. Those slides are on the website. And one time, one of new resident who came from different hospital said, "This lecture is very good. Can you see this?" That was my lecture, except my name was not there. So that is okay. They can have it.
That's the reason I said that it's very important to acknowledge it, and I think sometimes that's important to learn, that we must accept that. There is a question from Tarun Ghosh, and also, is hypomagnesemia related to cardiac arrhythmias? Do you think that there are some cardiac arrhythmias which might happen with hypomagnesemia?
Absolutely. I mean, Dr. Vinayak can answer that, but definitely, yes.
There is a if you look at the observational studies, and this topic is actually heating up about the effect of PPIs on cardiovascular adverse outcomes. In the last 2 years, 2017 to 2019, there are at least 10 articles which have kind of raised a red herring about PPIs in cardiovascular disease. One of the mechanisms of sudden cardiac deaths or maybe increased mortality in these patients could be because of arrhythmias. Hypomagnesemia may be a putative mechanism by which it could be happening. It is not substantiated yet, but then this is how the discussions evolve and the studies are undertaken to look at the mechanisms. So I think there is enough ground to look into these things, and probably in the next couple of years you'll have more data to substantiate that theory.
So torsade de pointes is a known manifestation of severe hypomagnesemia, isn't it?
True. Very true.
Pradeep, one of the questions says that, is it a specific PPI or is it a class effect of PPIs that has been associated with it? Is one PPI more effective as a cause for chronic kidney disease or any of these abnormalities?
Yeah, it is a class effect, and most of the PPIs are associated with acute interstitial nephritis and chronic kidney disease. There is a slide actually there where it is showing omeprazole may be the worst.
Yeah, actually, there is another question related to, there are a lot of nephrologists, I can see them here, and Dr. Vikram from Dehradun is suggesting that, that is there a time duration or a safe limit of use of PPIs? Would you think that you will be, without any kidney disease, using, if you use PPIs for, say, 8 weeks, we are saying 8 weeks.
You answered that question, Dr. Kher, sir. I mean, you cannot 100% say that you will use it for 4 weeks and 8 weeks or 16 weeks, nothing will happen. But chances would be much, much lower. Most important thing is to use medication when there is an indication.
Yes, I think that's important. And I feel that, see, you can get an acute interstitial nephritis as an allergic. This is an allergic hypersensitivity reaction which occurs in some patients. So this can happen even with one tablet or even with 1 day's use, or it would be. You have yourself suggested that the duration time may vary from 1 month to about 39 months or 30 months. You had in your slide suggested that. So I think this question probably that AKI can occur, as we know, the AIN will occur with any of these drugs with a single use. It's a hypersensitivity reaction, occurs in a small percentage of people, but it does occur. And if it occurs, you will have to identify this, maybe biopsy it if you suspect it. And if you find that there is an acute interstitial nephritis, maybe a short course of steroids in that kind of a setting and withdrawal of the drug. That's the most important thing. I think the most important treatment for acute interstitial nephritis related to drug is to withdraw that drug and then maybe treat that, because it can quickly lead into chronic kidney disease. Acute interstitial nephritis, if not identified, will progress into chronic kidney disease, and I think that's important.
Can I ask a question to our panel here? Do you think PPIs, based on current data, mainly through observational studies, I agree, should they be removed from the over-the-counter drug status? Should they be an OTC anymore?
I think with I would see that there is good reason to say that they should be removed from PPI from over-the-counter use, and I think there is, because the literature on chronic kidney disease over the last 6-7 years is growing. There is newer incidence of gastric cancers and other things which is also coming up now, and cardiovascular disease now coming up. So I think there's no reason why you should be giving this drug or making it available for over-the-counter use, which actually helps in indiscriminate use of this drug. I think that's an important idea.
Yeah, because I will give a parallel. Sorry, carry on, please.
Yeah, Pradeep.
So this is a very difficult in United States to answer this question, to be very honest. PPI is a new cause of CKD or AIN. Non-steroidals are guilty worse, and they have been going and they are available everywhere. And to get a prescription from a doctor, you need an appointment. To take an appointment, especially in United States, it doesn't happen same day. So if you are sick or pain, you go to ER and you wait there for 3-4 hours. So it becomes a practical issue here. That is the only thing I would add. And I want to say other thing beside renal and cardiology and gastric. One of the very important side effects of PPI is osteoporosis. Yes. And osteoporosis is becoming a problem everywhere. We are becoming, every life expectancy, when I wrote my first paper on AKI, you remember in India was 59 years. And now it is 68, 69. Yeah. So population is growing. Elderly population is growing. Osteoporosis is increasing. Hip fracture is increasing. And we need to avoid these drugs to avoid osteoporosis also.
I actually would like to take a simile with aspirin. Like now we have, last 3 years, we have at least 4 major trials which have shown that aspirin and primary prevention is to be avoided, and that it may actually cause significant amount of major bleeding. So I think that a lot of age-old concepts are being demolished, and I think PPI is next. That's what I feel. And this indiscriminate use of any drug is probably going to be questioned, in the next few years.
Yeah, I think if not the regulatory authorities, the patients themselves are going to. Many patients these days are reading the literature. They come with a lot of questions, and they question many times, why is this drug being given? What are you giving it for? How long should I be taking this drug? And I think it's important. I think it's important that patients become educated and they question the doctor as to how long should this drug be given, and is it. They're reading literature, and I think it's important. It brings out also an objectivity amongst the doctors about treating their patients more effectively. I think there is a question from a lot of nephrologists here, and some questions are being asked from me as well, that we have large number of patients on PPI and we hardly find them suffering from AKI or other. Most of the time we are treating patients of chronic kidney disease where the cause is unknown. And we usually say that the cause is diabetes, or even in patients with diabetes, we presume the diabetes is the cause of chronic kidney disease. We never sure whether the cause is chronic kidney disease or diabetic nephropathy, unless there are very specific classical kind of signs and symptoms, or the history is like that you might think that. But even in those patients where there is a classical cause, the natural cause fits in, but we are never going to be sure unless you really do a biopsy in these patients, and we don't biopsy patients of chronic kidney disease. Many of them come so late. Many times in patients where there is an acute deterioration in kidney function, we don't biopsy these patients because of many reasons. Some may be also involved that we are not aggressive in biopsying these patients. We feel that this kidney function will come back to normal or will improve, but it may not improve. So many times what we practice may not necessarily be based on a lot of science and objectivity. We also take into consideration whether biopsy is going to be feasible, patient is on anticoagulants, maybe we don't, we treat them empirically and look at the impact of that treatment sometimes, follow these patients for some period of time. But that doesn't necessarily mean that we should continue to use drugs where there is no indication. I cannot justify this question saying that I am not seeing adverse effects of this drug. Whether this is indicated or not indicated, I will continue to use it. I don't think that's good science. That's not good medicine. That's not good clinical medicine. So I think it's important to see that if there is an indication to use a particular drug, do give it. PPIs have been shown to be, maybe there is evidence to show that PPIs may be better for treating certain diseases than the acid inhibitors, other acid inhibitors, H2 blockers. Yeah. So in that sense, for short-term usage, I think they are indicated. You already mentioned some of the indications where FDA approved it. I think those are good indications for using this drug, but they all have time limits of their usage. Usually will recover in about 8 weeks, 12 weeks, or 16 weeks of time. There is not, I didn't see any condition in that where prolonged usage for longer period of time. And if they are not indicated, there's no reason why I should be using them, especially when there is growing evidence. This may not be proven, but if there is evidence suggesting that there can be potential harm, why should I use it?
So it's a very interesting thing. I was talking to one of my batchmates who's a gastroenterologist from a very reputed institute, and the gastroenterologists per se are not convinced about the adverse effects of PPIs in general as yet. They know that it causes adverse effects on kidney, on bones, osteoporosis, osteopenia. But I think it's very important that the highest prescribers of PPIs would be gastroenterologists, probably followed by cardiologists. And I think this topic is of a lot of importance for the next maybe 2-3 years, where this should be brought up in most of the conferences as to, what is the data behind this indiscriminate use? Do we actually have the data to prescribe it? And should we start de-prescribing them, a lot of patients?
Yeah, I think there is a need to look at this growing evidence of literature which suggests incrimination of some of these drugs. And there is a question about to you, Dr. Vinayak, and that is the American Heart Association says that PPI has been shown to significantly reduce cardiac mortality than ranitidine. Would you like to have a comment? Is there an evidence to show that?
No. So basically, if you look at the entire data, so what he's referring to is that there is a paper in BMJ 2019 also where they've shown that if you look at the adverse effect, gastrointestinal adverse effects in cardiac patients who have undergone stenting, PPIs are better than H2 blockers in decreasing those adverse effects pertaining to the GI symptomatology. In fact, in the same paper, they mentioned that the platelet reactivity remains high in these patients if they are on PPIs as compared to H2 blockers, which means that the high platelet reactivity, which means that they are more prone to stent thrombosis, more prone to MIs and all, actually remains higher. So it is difficult to say at this moment whether that actually translates into higher cardiac mortality or not, because these are observational studies. but I would not agree that they decrease cardiovascular mortality.
Yeah, there is also another question which says that this is from, I think I must say, Dr. Vinod Soni. He says that many patients who are using PPIs for long periods of time haven't developed chronic kidney disease. He doesn't see it in his practice, and therefore he questions whether there is evidence. I must answer this question saying that diabetes as a cause of chronic kidney disease occurs in only 30 to 45% of patients. 30 to 40% of patients with diabetes develop diabetic kidney disease. That doesn't remove diabetes as an important cause of chronic renal failure in this country. It is the commonest cause of chronic kidney disease across the world. But it occurs only in 30 to 40% of patients. Not everybody with PPI usage will develop. Not everybody with particular drug usage will develop that disease. But it is a higher percentage of people who are going to develop these, and that happens all across. If you give a bacteria of, say, cholera injection into a person, not everybody will develop cholera, I can tell you. If you inject E. coli into the kidney itself, not everybody will develop UTI. Only small percentage of people will die. That doesn't mean that we should be injecting these bacteria into the, or we should be continuing to use these drugs if there is growing evidence. You can close your ears and eyes to the growing evidence. That's at your own peril, but I don't see a reason why one should continue to use these drugs if there is good amount of evidence which is coming. You may not, the evidence may not yet be so strong in the sense that based on science, but there is a growing, if there is an indication, I'm not saying that you should not use PPIs. If anybody is getting this, please remove that. We are only saying inappropriate use of proton pump inhibitors. Proton pump inhibitors are excellent drugs. There is a good indication for their usage in those conditions. They should be used for short-term period, and they should be discontinued after there is no indication for their continued use. And I think because they have adverse effects, this is true not only for PPIs, I would say that this is true for every drug that one should be using, and I think that should probably sort of suggest that there is no reason why we should continue to argue as far as people don't see chronic. There are many similar questions actually from many other people as well. Acute gastric disease, they're saying that if there is an acute gastric disease, unfortunately none of us are here are gastroenterologists, and we've now not been practicing active gastroenterology for many years, so therefore we may not be the best people to answer this question. But as physicians, I would say that if there is an acute gastric condition which requires a PPI, I think we should use it. I would strongly recommend their use for conditions where there is an indication of acid peptic disease, ulcer disease and all that, but their use should be limited for a short period of time. Is there any other question? Vinayak, you have anything else you would want to?
No, I think I'm hoping that the discussions that have happened till now are in no way trying to denounce the utility of the PPIs, which have been here for a long time, and we've all been using it personally as well. I think the whole discussion is to raise certain concerns about possible adverse effects, because we have quite a number of sufficient data, actually I would say, to raise concerns. There are observational studies, there are studies which Dr. Pradeep showed, which are of major concern to me at least, because in cardiology, I don't remember in the last 20 years of my practice where I think almost all the cardiologists put patients on PPIs. And not only is it a big cost burden, but now that we look at the side effects as kidney injury, CKD, the possibility of osteoporosis, osteopenia, and even increased risk of enteric infections, risk of gastric cancers and all. I think these are something which are of major concern. We should, right now, we should decrease the indiscriminate use straight away.
Absolutely, and especially in hospitalized patient in ICU, PPI use is not only associated with increased risk of pneumonia, and that is why indication of PPI in all ventilator patient to use as GI prophylaxis is going away. C. diff colitis. There is a strong evidence that it is associated with C. diff colitis. So there are a lot more side effects. We didn't discuss those, but they are there. And again, as everybody is saying, use this drug when it is indicated. Do not use this drug. And I remember when I was working, actually, when Dr. Kher was teaching me, one of the important thing in chronic kidney disease was when you see a patient, look at the acute reversible, potentially acute reversible factor. And one of the acute potential reversible factor used to be look at the medication. And that is what I took from India to here, and that is what I teach here, and I follow it too. And it is time consuming. Thank you, Dr. Kher, for that.
Pradeep, I think it's, if one looks at, I think there was a survey of the drug prescriptions across specialities, and the PPI usage came out to be the commonest drug prescription from cardiologists, nephrologists, physicians, gastroenterologists. It was even more than any other drug that the cardiologist prescribed. Maybe more than the ecosprin, and because it continued for even beyond that. So I think it is the commonest drug which is being used across and abused. I think there is a question from Dr. D.N. Moharana, Professor Head from SCB Medical College, Cuttack. He says that ESRD patients getting injectable PPIs, how far is it rational, or how far should it be given, and how long? So would you take up, Pradeep, this?
I mean, why would, I mean, IV PPI would be given only in admitted patient, and especially when they are needing it for some reason. Why they would be getting IV PPIs? And as I said, PPI causing hypomagnesemia is due to GI mechanism, not through renal mechanism. So that can cause hypomagnesemia with all its risk of hypomagnesemia. So I mean, I do not use IV PPIs unless person is bleeding in ICU. But in dialysis patient, why would be using it?
No, he's talking in the ICU probably. ESRD getting
stress ulcers or whatever.
We have to, if there is a stress ulcer, to prevent it, as I said, if they are intubated, there is a more risk of death due to pneumonia than stress ulcer. I mean, concept when I was resident till now has taken a sea change. This used to be a board question in medicine, PPI prophylaxis or H2 blocker prophylaxis in ventilated patient. Now the question is still there, but answer is reversed. You don't use it routinely to prevent GI bleed in intubated patient. And the reason is pneumonia and C. diff colitis.
I think probably it would be reserved for patients who are on steroids, who are a known case of GI bleed in the past,
yes,
or who have come with anemia of unknown origin. I think in them, if we have a reasonable, say, doubt about the possible etiology, we may start it. But indiscriminate use again is something which should be discouraged.
Yeah, obviously we will try to find out the cause. If there is an ulcer in the stomach or in the antrum, I'm sure people will use PPIs. We should use the PPI.
Yeah.
There is no doubt about that. And I think we should use it once the ulcer gets cured and recovers completely. One should try to discontinue this. And if one has to still use, then one should use maybe H2 receptor blockers. The reason being why H2 receptor blockers may have to be, because this is an irreversible hydrogen suppression. With PPIs, there is an irreversible hydrogen suppression, and synthesis of hydrogen goes down. So that's important. And I think the intestinal microbiome is becoming a very, very interesting and an important mechanism of alterations of the microbiome is very being pathologically now incriminated in almost every disease that people have started looking at. So microbiome becomes very, very important, and altering this microbiome by many of these drugs would be something which I would not want. And PPIs are strong drugs to alter this microbiome. So I don't think that that's what one should continue to use it. I think we have most of the questions were repetitions, and so I may not have given the names of many of the physicians who have asked the questions, but I must thank all of them. It seems to be the number of questions which have come from people, maybe repetition of the same thing which we have discussed. And if I have missed one or two questions which may be burning, maybe we could, I'm sure you can take those questions and I can take those questions, and Pawan, you can record if there is a question which comes again, and we will be more than willing to try to answer and find evidence for that, and we will reply to them on emails. We have emails of most of the people here, and so we should be able to answer some of those questions which may not have been sort of touched here, and we will continue to be on page with you on this topic. This is a topic, as more and more evidence starts coming in, and if there is greater evidence and more scientific evidence which comes in, we will surely bring it to you. With this, I must thank Pradeep, you first of all, for being early on a Saturday when you are on call, giving some time and sparing this. It's been a privilege to listen to you, and thank you very much. And I must thank my colleague, Dr. Vinayak. Vinayak is, we were in the morning, we were again on another session together, but it's pleasure always to have Vinayak with me, and thank you Vinayak, for bringing different levels of answers to many of the questions which we had here. Thank you very much, all of you, and